The next time you go shopping and you're walking down the aisle and five people, one of them is carrying this potentially lethal gene that's going to affect their heart
Yeah.
in very bad ways. That's unreal. There is
Hmm.
nothing in lipids that is that prevalent for sure. Here's where it gets even worse. In Asians, it's almost 1 out of 3. In women, also about 1 out of 3. And in African Americans, almost one out of every other person. This is
Wow.
incredibly prevalent in that race. So again, this is not some bizarre little lipoprotein goofy syndrome we're going to be talking about today. It is so prevalent. And the tragic news, although the guidelines hopefully to address that now, is the overwhelming vast majority of physicians and even cardiologists are not testing for LP little.
Nope. Nope.
And that is a tragedy. My God, if there was a cancer that was afflicting 20% of people and we had a blood test that tells you you're going to get it, people be running to the laboratories to get their blood tested.
Welcome to the Everyday Epigenetics Raw, Real, Relatable podcast. I'm your host, Susan Robbins, epigenetic human performance coach. This is where we discuss all things lifestyle, environment, food, exercise, work, mind, and social interaction as they pertain to epigenetic expression in a way that's relatable to everyone. So if you're ready to start viewing you as an individual, take control of your life and health, and get results, buckle up, here we go.
Welcome to the Everyday Epigenetics Raw, Real, Relatable podcast. I'm your host, Susan Robbins. This is the place where we talk about everything lifestyle and environment and how it relates to our genetic expression. Today, my returning guest, Dr. Tom Dayspring, aka Dr. Lipid.
Correct.
This is he's last week. So this is a part 2 of a 2-part series we're doing on genetic-based lipid disorders that are supposed to be super rare, but I wanted to bring this to you guys' attention, my listeners' attention, because I am seeing this more and more in my practice. And again, I'm trying to help you be your best medical advocate and understand what's happening with your body and how to work with it. So last week, we talked about plant sterol buildup. Today is going to be one a little more common, but it's called LP little a. And again, I've listened to other podcasts and there were things all over the place that I was hearing. So Dr. Lipid is going to give us the facts today on LP little a. He needs no introduction. It was a long one last week, so we're just going to roll right into it today and not bore you guys with a whole bunch of intro stuff and get down to the meat and potatoes. So buckle in for some LP little a. Dr. Dayspring, I'm going to give you the floor here to tell us what the heck is LP little a.
Yes, most importantly, it is the most common genetic lipid disorder that is on the planet, and it is highly associated with premature atherosclerosis, but also calcific aortic stenosis. That aortic stenosis means a narrowing of the main valve in the heart. When the left ventricle pumps, blood has to go through the aortic valve, then into your aorta and everywhere else. And obviously, if that valve starts getting narrowed, that's no good. The heart can't pump it out. The heart enlarges. Ultimately, it's a cause of heart failure and other cardiac morbidities. So this is the genetic abnormality that can lead to either of those conditions. And of course, atherosclerosis is the leading global cause of death and even morbidity. So if there is a genetic cause of this, it's important to know. And in fact, all guidelines of substance, European Atherosclerosis Society, National Lipid Association, and the most recent American Heart Association guidelines suggest that every human be tested once in their life, because you either have the genes that this particle we're going to talk about, or you do not. You don't have to repeat it every year to see, oh my God, is it going to be positive now? No, it's
Right.
positive from the day you're born to the day you die. So one-time testing. Right now, repeat testing, there's some instances where you might want to do it, but in general, until we get a therapy that dramatically lowers LP little a, that is proven to reduce the morbidities I talked about, there's no need to really waste your money repeating this blood test. The other interesting thing before we tell you exactly what it is, it's highly related to various ethnicities and race. In Caucasians, it's 20% of humans walking the planet. That's 1 out of 5. The
Wow.
next time you go shopping and you're walking down the aisle, and 5 people, one of them is carrying this potentially lethal gene that's going to affect their heart
Yeah.
in very bad ways. That's unreal. There is
Hmm.
nothing in lipids that is that prevalent for sure. Here's where it gets even worse. In Asians, it's almost 1 out of 3. In women, also about 1 out of 3. And in African Americans, almost 1 out of every other person. This is
Wow.
incredibly prevalent in that race. So again, this is not some bizarre little lipoprotein goofy syndrome we're going to be talking about today. It is so prevalent. And the tragic news, although the guidelines hopefully to address that now, is the overwhelming vast majority of physicians and even cardiologists are not testing for LP little.
Nope. Nope.
And that is a tragedy. My God, if there was a cancer that was afflicting 20% of people and we had a blood test that tells you you're going to get it, people be running to the laboratories to get their blood tested. But this is not tested. Doctors have never been taught about this. It's going to change, but it's a slow change,
Yeah.
even despite the guideline. So, what is lipoprotein little a? We last week talked a little bit. A lipoprotein is simply a collection of lipids that is surrounded by a protein that makes the little oil droplet soluble in plasma. So if you take lipids plus a protein, you have a lipoprotein. And the lipoproteins are created in the liver or the small intestine, and they're thrown into plasma where they can traffic lipids to appropriate places or bring unwanted lipids back to the liver or the small intestine. The lipoproteins are really in 2 categories, depending on what is the structural protein enwrapping them. And we have one family called the ApoB, apolipoprotein B containing family. And there is one big ApoB peptide that surrounds a bunch of cholesterol and triglycerides and other lipids, and that is the ApoB family. People probably don't classifying by that, but here's the members of that family: low density lipoproteins, LDLs, which
LDL.
everybody knows, and very
Mhm.
low density lipoproteins, which more and more people are learning about too. By far, LDLs outnumber VLDLs, but those are the 2 major ApoB particles, except there's going to be one more that I'll tell you about in a second. The other family of lipoproteins are much smaller, and they are surrounded by a couple of peptides or a couple of copies of the apoprotein capital A-1, apoprotein A1. And notice I said capital A. This is going to be crucial. So if you order a blood test, ApoA1, you're basically ordering a metric that tells you something about high density lipoproteins. All right. But if you have a gene that produces another apolipoprotein called apolipoprotein little a, that means small case. It's not a capital A. That is what we're going to be talking about today, lipoprotein little a. So let's go back to when it was discovered, 1963, by a Norwegian chemist who was experimenting with lipoproteins. So he separated lipoproteins in a centrifuge, but then he created some antibodies in rabbits. And he took the rabbit antibodies and he threw them in the tube that had the human lipoproteins. And he says, wait a minute, this is funny. One of the rabbit antibodies is sticking to LDL particles. So in chemistry, that means the LDL has to have something that is attracting the antibody, and that is called an antigen. So he noticed that some LDLs, certainly not in everybody, this rabbit antibody would stick to the LDLs. So back in 1963, when you discovered an antigen, the nomenclature was small a. So he discovered an antigen, little a, that attached, that he says was on some LDL particles. And he says LDL is a lipoprotein, and now it has an antigen on it, lipoprotein little a. So that's, and the
LP little
nomenclature
a.
has stuck and has never changed. He had no idea what he discovered, except there was a unique type of LDL particle. So remember the ApoB family of particles?
Sure
LDLs
do.
one of them. So what the heck is lipoprotein little a? Because it sounds like something was sticking to the LDL particle when Berg discovered it. And indeed, proteins are made in the liver. The liver has a protein making apparatus. It's called an endoplasmic reticulum. And that protein making apparatus responds to genes because it's the genes that are transcripted and they tell these endoplasmic here, make this protein, make that protein, stop making this protein. So genes control everything with protein production. So if you inherit a gene, and the gene is called LPA, and obviously, but gene nomenclature is LPA, all capitals, but they're in italics. You don't see
Yes.
LP little a when you're looking at the gene that is going to control the construction of apoprotein little a. So if
Correct.
you inherit the genes, and how would you inherit the LPA gene? Most of us have a mother and a father who are contributing to our genetic makeup. And we get one allele, one copy of a gene from mom and one copy of dad's. So if either of those are carrying the LPA gene, this is called
There we go.
codominant inheritance because if you inherit that gene, it's going to definitely control the protein that's being made, regardless of what the other allele says or not. Codominant inheritance. So either mom or dad has it, there's a 50% chance that their children are going to have it. If both mom and dad have it, it's a 100% chance.
Oh, so that was my question. I have a couple right now, and they both have the genetics for it because I run it on my tests. But on their labs it came up and they're both high, and they have two kids, two or three kids. So they would definitely want to have their kids tested to be aware of this because with both of them having it, well,
Everybody should be tested.
yeah,
So that
right.
now in the old days, certainly if you discovered what you discovered, you'd want to do it. There is a little thing with children. The LP little a concentrations don't reach the adult level until around the age of 5. So you wouldn't want to screen a 2-year-old for it.
Oh,
And,
God,
and
yeah,
even kids who pediatric guidelines say should have a lipid profile by around the age of 9. Right now, they are not saying throw in an LP little a, but I say, why not?
why
If you're
not,
testing a
right?
kid
Yeah,
for a genetic lipid disorder using a lipid panel, why not? Hey, this is way more common than most other lipids, way more common than familial hypercholesterolemia, which is the reason they want 9-year-olds tested.
and
So
and my concern with this couple, they're in their 60s and their children are having children.
sure. Look, it's
So
like
that's
any
good to
other
know.
you deal with genes. When you
Yeah,
discover a serious gene, depending how it's passed on, you do what's called cascade testing. You start testing relatives for the gene because if you find it and it's a gene that is going to affect your health, why wouldn't you want to know about that? So
exactly.
you get a phone call from your brother and say, I'm sorry, I went to the doc and my LP little a is tested. Please, that brother, the other brother should, next time he visits the doc, ask for it to be tested. And of course, the kids. Some people have long said, why test it? Because you can't treat it. But there is definitely ways of treating it nowadays. So that's an
Mhm.
absurd argument to say there are all sorts of treatments that would be applied to somebody with LP little a nowadays. And in the future, we're likely going to have incredibly better treatments than we do now. But even today, there are. So if you inherit that LPA gene from mom or dad, your protein making apparatus is going to construct a peptide, a protein called apoprotein little a. And when you ask, that protein is going to leave the protein making apparatus. It's now in the cytosol, in the cell. But what else is the cell producing in the liver? Low density lipoproteins, LDLs, which is an ApoB particle. So, what we call a primordial LDL, that's like a beginning LDL particle that the liver is creating, will have some cholesterol, will have some triglycerides, and it'll be wrapped by a single apolipoprotein B. Now, this apoprotein little a, that if your protein making apparatus made it, basically is going to swim over and there's one little segment on apoprotein little a that binds to apolipoprotein B. So you take an LDL particle with ApoB, you take an ApoA peptide, and they glue together, they stick together. what's called the disulfide bond. It's two sulfur atoms that connect the two, and it's a covalent bond, so it's very strong. So now some of your LDL particles are carrying what I call an interloper, apoprotein little a, that shouldn't be there. But wait a minute, an LDL is an ApoB containing lipoprotein. So I told you VLDLs and LDLs are part of the ApoB family. We will now add LP little a to the ApoB family of lipoproteins. And of course, once the LDL attaches to apoprotein little a, in your liver now you have LP little a particles that are rapidly secreted into the plasma where they can be measured. That's where we're measuring them, of course. And there are concentration thresholds that if you're above a certain level, you have increased apoprotein little a. Everybody has the genes for LP little a, but not everybody has the SNP that's going to tell you to produce really high amounts of apoprotein little a. So if you take 4 out of 5 people on the planet, and we'll say the Caucasians, 80% of them will not have increased concentrations of LP little a, but they will have a concentration of LP little a, but it's low. And we know from epidemiologic studies below certain levels, even though you have an eensy weensy bit of LP little a, there's no harm that's going to come to your heart from it. And as the level goes up, it's sort of like ApoB, it's like LDL cholesterol. The higher it goes, the worse the risk. Every lab in America does this test. Every lab, I would think, throughout most of the civilized worlds where there are labs, this test can be done. It's complicated because the assays are tricky and they're not standardized. So you might check it in one lab and then next month you check it in another lab. They both should correlate. They're both high, both low, but there might be differences or so because the labs are using different assays. And only about a year and a half ago did the FDA finally certify an LP little a assay. So there's many ways we can go. Let me just tell you, if you are going to check LP little a, what are the concentrations that you might want to worry about? And there are 2 ways that laboratories used to report the concentrations of LP little a. Most are transitioning to a level I'm going to talk to you about. And the guidelines demand that laboratories should be testing with 1 metric. So in the past, but even today, some labs will give you a mass metric. That is LP little a in milligrams per deciliter. And what that is doing, the laboratory separates your LP little a particles from the LDL particles and all the other lipoproteins. And it basically puts them on a scale and weighs them. And if you stepped on a scale, you would be so many milligrams. It's a lot, so it's translated kilograms. But yeah, it's a sort of mass is reported in milligrams. But what you're actually weighing is not only the apo little a protein, but the ApoB protein, all the cholesterol molecules, all the triglyceride molecules, all the everything else that's on an LDL particle. But nonetheless, apoprotein little a does add weight to the LP little a particle or mass. So if your LDLs are carrying apoprotein little a, the concentration is going to be a little higher than if they're not. So that is milligrams per deciliter in the States. And typically it said if you exceed 30 milligrams per deciliter of you have an increased LP little a concentration. The risk really starts to get high when you exceed 50 milligrams per deciliter. And if you have 300 milligrams per deciliter,
you're in trouble.
Astronomical levels of LP little a. Now, the other way that most labs are starting to report it in which the guidelines demand, is in molar concentration. And they are reported in nanomoles per liter. A nanomole is a billionth of a mole. Just keep that in mind. Moles are you're actually counting things. If I had 10 moles of cars, I would have 10 cars, so to speak. So if you have under 50 nanomoles per liter of LP little a, that is within a normal range. Most people will run 10 to 20, but up until about 50, you're not considered to have risk. Now, obviously, when it increases above 50 nanomoles per liter, you enter the world of potential risk from your LP little a particle. And when it hits 70, little more risky. And the guidelines now, the most recent one calls any level above 105 nanometers per liter is high risk. That's the high level. Between 70 and 105, you're in this intermediate risk category. And below 50, you're in the low risk category. So
Okay.
those are the two metrics people, if they get tested, will see, and they'll be able to interpret them. And later on, we'll talk what can you do about it or so. As we mentioned before, the first thing you do is get your kids tested
Get
and
kids tested.
your first degree relatives.
Because I hear people say, "Oh, I'm not going to change my lifestyle. I'm not going to do anything because there's nothing you can do to work with it. Nothing." They're
Well,
having in their head that there is nothing you can do to lower.
Sure. When we
lower
get
limit.
into how would one approach this, if you read the guidelines and the very excellent deep dive reviews on this, numerous studies have looked at it. In general, LP little a does not respond to lifestyle, whatever diet you want, whatever exercise regimen you want to go on. Now, every once in a while, you'll see on the internet that somebody went on some diet that they invented, and they say, my LP little a dropped. And the problem is, if you're in the high risk zone, you drop it a bit, but you're still in the high risk
You're still in
zone.
the high
So
risk. And I talked to you about
therefore,
that
you
last
really
week.
haven't changed your risk by whatever diet you're doing.
Yeah.
Now,
Yeah.
listen, this does not mean we tell people with LP little a, don't, your diet is
Don't
irrelevant. Of course not.
hog.
Diet is incredibly important to prevent all forms of cardiovascular. So even though you're not lowering LP little a, you're probably helping your blood pressure, you're helping your ApoB,
And the
you're
B,
helping other
yes.
metabolic disarray you may have. So diet and lifestyle is crucial with anybody who's at risk
Thank
for
you.
atherosclerotic heart disease. So please, just because the guidelines say diet doesn't matter, diet matters with reducing everything else. And the current way to approach LP little a, because there are no FDA approved drugs that say, hey, if you take this drug, you're going to have less heart attacks or strokes or the things that LP little a causes. There is one drug that you could use off label, which we'll talk about in a little while. But in general, what the guidelines say, okay, you have high LP little a, get on the proper lifestyle, but then lower your ApoB or your surrogates of ApoB, LDL cholesterol and non-HDL cholesterol as aggressively as you can. And that's the proper treatment for it. Control blood pressure, stop smoking. Obviously, anything that reduces heart disease is on the table if you have high LP little a. But because the lifestyle doesn't lower it where we believe it should be, this is where most people have to go on pharmacological LDL ApoB lowering drugs. And of course, the most simple and the most readily available and the one most tested would be the statin therapy. But statins, ezetimibe, bempedoic acid are all pharmacological lipid modulating agents that are used. Since we're expounding on treatment a little bit, there is a very powerful ApoB lowering drug called a PCSK9 inhibitor. Right now, it's an injectable drug every month or every 6 months, depending which one you choose. In development, and probably within the year, we will have an oral PCSK9 inhibitor, but it's not available yet. Interesting, that class of drugs lowers LP little a by about 25%. It might do it more in one person, it might do it a little bit less in another person, but on average, 25%. Now, here's the thing. Does lowering LP little a, especially if you're in a high risk group by 25%, you're still probably in a high risk zone. Does that matter? We do not know that yet. We need a large clinical trial using a drug that lowers LP little a to say, yes, if you lower LP little a, there will be less heart attacks and strokes. And here's how much you really have to lower LP little a to start getting benefit. We'll probably have that data within a year or so, but right now we do not. Nonetheless, there are two trials using PCSK9 inhibitors, very high risk people who had heart attacks or strokes. They took PCSK9 inhibitors and they lowered LP little a by about 25%. And that was tied into improved benefit. Now, that's what we call post hoc analysis. That is hypothesis generating data. It's not you can bank on it type of data. But more and more now, the physicians are prescribing PCSK9 inhibitors off-label. That means the FDA says this drug is not approved to lower LP little a, but you can prescribe a drug for wherever you want once it's on the market. If it's on the market, the FDA has just basically said this drug is safe and should be used to lower LDL cholesterol and ApoB. But if you want to use it to treat a runny nose, go ahead and do it. So it's up to doctors to use what drugs once they're on the market. So more and more of that drug is being used. Of course, its downside is since it's not approved by the FDA for LP little a lowering, a third-party payer will not reimburse you for it, and they're expensive, anywhere $400, $500, $600 a month. So that's
That's a lot. Yeah, that's
most people or
tough
so.
for people.
Before I go back to a little bit more of the biochemistry with LP little a, any questions you have, Susan, so far on what we discussed?
So really, just so I'm clear, you don't want to just take lifestyle and throw it out the door. You want to look at the other lipids. So when you're doing a lipid panel, do not ever just look at cholesterol and triglycerides. Look at the apolipoprotein B, which is a big one.
You're counting ApoB particles with ApoB, and LP little a is one of the ApoB
and LP little a is one. So you can do the LPA once and know that you're and it's not an expensive test, because I added on as like a onesie twosie onto my panels, and it's $17 or something. It's really cash price. It's super inexpensive to get this. So my another question, and I had brought this up to you last week when you and I had talked off air. My male client in his 60s, very high LP, it was 130, 133, I think it was. And in 2.5 months, now this was just lifestyle, we lowered it 30 points. So it's still in the high range, but that's where I say you have nothing to lose by changing your lifestyle.
No, and I would bet that
his ApoB dropped too.
I would bet that lifestyle reduced the ApoB level.
Exactly.
So that's good.
And here's my other question. Because the influencers say you don't have to look at fats or anything. It's all insulin. It's all sugar driven. Okay. We also dropped his insulin almost 10 points. So is insulin resistance also a big driver?
Well, that's a separate cardiovascular risk factor that you would definitely want to control. If you have a diabetic with LP little a, or a pre-diabetic, or even an insulin resistant person whose glucose hasn't exceeded 100, you would want to get rid of insulin resistance because it's a terrible metabolic abnormality. And weight loss is one of the mainstay of initial treatments to improve insulin resistance. And improving insulin sensitivity, the opposite of that's fighting insulin resistance, is usually it's going to lower triglycerides, which lowers ApoB in the process in many people. So the lifestyle is crucial. So, but again, if you're a diabetic and you control your insulin and you can control your lipids, you're helping yourself, but you're still at risk for LP little a mediated disease. The very sad news is, even though we want to lower ApoB and LDL cholesterol as much as possible, even in some people with normal LDL cholesterol, normal ApoB, normal non-HDL cholesterol, LP little a can still create havoc. So in general, that's a big part of the treatment, but you can't say, God, I've got a perfect LDL cholesterol, ApoB, I'm at no risk anymore. Your risk is much lower, but you're still at residual risk. Until we get a therapy that stops your liver from producing the apoprotein little a peptide, that is going to be the only way to hopefully wipe out this disease. Those trials are in progress right now with very powerful drugs that act through altering genes that will stop your liver from making apoprotein little a. And we hope that and they reduce it 80, 90, 100% apoprotein little a. We're hoping that, number one, they're safe, and number two, that this dramatic lowering of LP little a just takes away the risk totally of atherosclerosis or calcific aortic stenosis. So that's the hope, and we'll see. The trial is nearing completion, the first trial. It has not been stopped for safety reasons. So we know the drug, which is called pelacarsen, PELACARSAN, is safe. Now all we need to know is We know from studies that it lowers it about 70%. Does it reduce heart attacks and strokes? So the fingers are crossed that it
Yeah.
does. Now, are there several other drugs in the pipeline, but they're a few years away from completing their trials.
Okay. So another question, if say another coach listening or nurse practitioner, or whoever, a physician that is not a lipid specialist, and you have a client or a patient that is showing all of these risks and has the high LP little a, would you refer to a cardiologist? Would you suggest that? Or would you say, do the research, you know what to prescribe here. If something needs to be prescribed, at the very least, work with the lifestyle, bring down the numbers around the LPA, get the client or patient into healthy realms everywhere else. Is that just so people are clear with where to go?
Here's
Because
my
it can be
answer to
confusing.
this. In the real world, if you have picked a family practitioner or primary care physician and internist who is well schooled and knows what LP little a is, and probably if they tested it without you telling them to test it, as they should, they probably have some knowledge of LP little a. So there's no reason a physician, any physician or nurse practitioner, whoever is doing primary care, physician's assistant, who had said, I'm going to just pull down, just published a month ago, the new American Heart Association guidelines right on the internet for free. And I'll go to the section of that guidelines that deals with LP little a, and it will tell them what I just said. Get them on a good lifestyle to prevent all heart disease. But then what is their LDL cholesterol? What is their non-HDL cholesterol? Or what is their ApoB? Lower that, and they would recommend starting those people on a statin therapy if the ApoB and LDL cholesterol is high. So the run-of-the-mill, decent schooled practitioner can do it. But if you have to go in and your clinician had no idea what LP little a is, but he's going to order it because you asked him, when that comes back and he says it's high or she says it's high, I think I'd ask for a referral. But here's the problem. I just told you there's 90% of cardiologists are not testing it. And a huge percentage of them do not know what LP little a is. So you wouldn't want to get referred to that cardiologist. So just do not assume a cardiologist really knows the ins and outs. Now, a sure bet would be if you could find a lipidologist in your community that they would know what they're doing with this. But they're few and far between and not always so easy to find. And sometimes because they're in such demand, it's 6 months before you can get in to see them. And look, make the appointment. 6 months goes by quickly, but in that 6 months, you can do your lifestyle. You can do your own homework and tell your primary care physician, look, I've read the American Heart, and they think I should be on a statin. Could you prescribe a statin for me? And then when you get to the lipidologist, they can take it steps further as they would. So basically, you have to be your own advocate, as with so many, you know that. Have a genetic disorder. I don't know what they're teaching young students nowadays. They probably get a lot more genetics than previous generations, but I wouldn't bet on it. So you have to be your own advocate, do your own homework. Please, this is a wonderful organization, the Family Heart Foundation. Just Google it. They are dedicated to genetic lipid disorders, and they deal with FH and LP little a. They have a whole section of incredibly good informational data that patients can read about and understand because it's written for the lay public. And if you need help, they are very good. You can contact them, and they will come up with a list of names of practitioners in your area who are schooled in LP little a. So it's getting easier and easier to get help on it. But please be very careful if your clinician didn't know what it was. If they didn't know what it was, I doubt they know much about telling you at a
I don't know if I'd want to take a chance there, right?
Yeah.
Especially with something that has
that's my answer to your
risks.
question. You got to do your homework when you, as you know, with most genetic disorders, you got to find out people who. And look, it's I think as I'm a lipidologist, I've been knowing about LP little a for 30 years. The last 7 years of my life was working in a laboratory where we did all sorts of things on developing new and better tests for LP little a. So I have an incredibly high understanding of it. Not obviously the run of the mill practitioner does not. But listen, on today's world, you can even go to AI and type in, I have LP little a, and you'll get some decent answers in most of them. I've
Sure.
checked them out. So there are ways to do your own homework on this. And look, to be honest with you, there are ways for your physicians to do their own homework. If they
And they
order a
should
blood
be.
test and it comes back all lit up, they ought to not Google it. Google's a thing of the past. Go to AI and get the real answer or refer to an appropriate person. So
Yeah.
there's a lot that can be offered to these people, and they have to seek that type of care.
Yeah, absolutely. Okay, so we can keep moving. My questions are answered. Thank you.
All right.
Hopefully I didn't throw
So
you too far
now
off the
let's
realm
get
there.
into biochemically what the heck is apoprotein little a, and why does it cause such havoc? Why is it such a dangerous protein? There's a lot of great proteins that do wonderful things. Why is this protein have the potential to do horrible things? And the funny thing is, in most people, that would be true. But there is the oddball patient who has very high LP little a, who nothing happens to them. They just live their normal lives. And this is a real enigma because, say, I got two people today with very high LP little a. Likely they're both at terrible risk for something, but I don't know that with certainty. But there are some emerging other tests that can further help us know, oh my God, you're not the one who's going to live to be 80 with high LP. We'll do. By the way, the havoc that it creates, I told you, is heart attacks, but it's a big risk factor for strokes, the narrowing and calcification of the aortic valve. But in children, it's not causing heart attacks in children. It's not causing aortic valve stenosis in children because it takes decades for that to happen. But it is a cause of pediatric stroke. So
Oh,
God forbid
wow.
any child has a stroke. It's like the first blood test that should be done. It's certainly not the major cause of stroke in children, but it is a cause, and that is on the differential. And I would hope pediatric neurologists or pediatricians know that. But so that would be the one instance where you would check LP little a in a little kid who's unfortunately had a stroke. Right now, you wouldn't screen him for it because you could say because there was nothing you could do that would prevent that stroke. And in the future, there probably will be, but not now. Apoprotein little a, I told you, is this peptide that your protein making apparatus makes. Now, part of the danger of why apoprotein little a causes atherosclerosis is two reasons. And one of them was thought to be it has procoagulant activity. In other words, it makes your blood more coagulable. Initially, it was thought to be related to one of the blood clotting factors. Not so much the case anymore. It really interferes with coagulation because induces platelet aggregation and platelet dysfunction, and also induces the release of something called tissue factor, which is a strong procoagulant. So you have hypercoagulable blood as one of the bad news problems with apoprotein little a. So here's when Berg says, hey, it's an antigen. About 20 years later, they had the equipment that could do much higher analysis of proteins and everything. And they found out, geez, apoprotein little a is very similar in structure to a clotting factor that we know. Now, plasmin is a clotting factor that is good to have because it dissolves clots. If you form clots, and that's good, let's say you get a cut, you want to have a clot, but you don't want to have that clot forever. So plasmin comes in and it dissolves. That's called a fibrinolytic protein. So there's a precursor protein to plasmin that we can measure and look at and say, hey, this is the coagulation factor that's a precursor to plasmin. And if we look at that protein using proteomic analysis, it can normally a protein should just be a straight line of molecules. It's a linear thing. But certain proteins start to fold and curve, and that greatly affects their function. So the protein that's going to be on apoprotein little a They looked at it, and it was a bunch of curly cues, loops, one loop after another. And those loops were called kringles. And they're named after a Danish pastry that is a looped pastry. So the chemist who was discovering what are these loops on apoprotein little a is, my God, they're kringles. So he named them kringles. So all a kringle is a bunch of amino acids bound together. That's what all proteins are. But certain amino acids that contain sulfur molecules bind and stick to each other. It's like a magnet. If you're walking down the street with a magnet and you press something that's metal, it picks it up. So if you have sulfur-containing cysteine amino acids, they start binding together, and that changes the shape of the protein, and you get these little curly cues.
Oh, and there's the curves.
Yeah, because there's cysteine molecules in there that
Gotcha.
are making these. It's not linear anymore because these two molecules decide they want to mate with each other, so they cause bends. They cause these kringles. There's only 100 other amino acids in the kringle, but it's a loop structure now. Now, the protein that they thought is called a clotting factor protein that becomes plasmin is plasminogen. So they looked at plasminogen when they discovered that, and they said, oh my God, it's got these curly cues called kringles. But interesting, there are 5 kringles in the prothrombin, or the precursor molecule there. And they named them 1, 2, 3, 4, 5. Kringles 1, 2, 3, 4, 5. Now, if you look at apoprotein little a, it's only got 2 kringles. And they had the exact structure of kringles 4 and 5 in plasminogen. So they didn't have kringles 1, 2, and 3. That was missing on apoprotein little a. So initially they said, hey, apoprotein little a is a truncated plasminogen. It has homology. That means it's similar, but it's not a perfect copy. There's differences between the two. But deduction said plasminogen is involved with clotting, and if apoprotein little a is a defective plasminogen, you won't be able to lyse your clots. Your clots would be worse. So for many years, it carried the reputation as it's a clotting factor because it's like a defective plasminogen, the precursor to plasmin, the fibrinolytic agent. That may still have a little bit of truth to it, but more of its coagulatory effect is on platelets and tissue factor nowadays than a defective plasminogen. So that's one bad reason why you don't want to have it. Let's face it, if you're going to have a clot or plaque in your artery and it's going to induce a clot, you don't want to have hypercoagulable blood. So that's another bad news. All right. So now let's get back. Apoprotein little a consists of kringles 4 and 5, like plasminogen. The kringle 5 on apoprotein little a is identical to the kringle 5 on plasminogen. But the kringle 4 on apoprotein little a is very, very different. And here's why. If we look at kringle 4 on apoprotein little a, they now have divided it into 10 subsegments. So kringle 4 actually has kringle 4 1, kringle 4 2, blah, 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 kringle 4, 8, 9, and 10. And in humans, kringle 4 subtype 1, 3, 4, 5, 6, 7, 8, 9, and 10 are all identical. Kringle 4 subtype 2 is different. When people start producing kringle 4 or subtype 4, the second thing can have multiple copies of the kringle. So therefore, how big is apoprotein little a? It depends on kringle 5, has a certain length. It's the same in everybody. That doesn't change. Everything before on the peptide, the molecules before kringle 4 is the same on everybody, but kringle 4 has different lengths in everybody because you can have anywhere from 10 to 50 copies of kringle 4 based on kringle 4 subtype 2. So if you're following me here, if you have the genes that produce 20 copies of kringle 4 on apoprotein little a, you will have a certain length of the overall apoprotein little a. But if you have the genes that tells your protein making apparatus make 50 copies of kringle 4 subtype 2, you will have an incredibly long apoprotein little a peptide. So there are different types of Kringle 4 based on Kringle 4 subtype 2. Remember, subtypes 1, 3, 4, 5, 6, 7, 8, 9, 10 are identical.
All the same.
They don't vary. But Kringle 4 subtype 2 varies on the number of copies of how many Kringles are in subtype 2. And it can vary so much. So people either make small, short in length apoprotein little a, or they make large, long length apoprotein little a. And this translates better. It's measured as molecular weight. So if you have a really short apoprotein little a, because you only have a few copies of Kringle 4 subtype 2, you have a low molecular weight apoprotein little a. Whereas if you have a lot of copies of Kringle 4 subtype 2, you have the very long apoprotein little a, you have a very high molecular weight apoprotein little a. So I hope everybody follows that because it matters. Not that you're going to test it. Go ahead, ask what you were going to.
And so that, again, just so I'm tracking here, because I'm not the deep dive science person here. Yeah. So I have this small attention span. So the people with the higher genetic risk are typically going to produce the longer ones.
No, it's
the opposite.
I just said that some people produce long, high molecular weight. Some people produce small. I didn't tell you how they're related to risk. It's going to be paradoxical. The big ones have much less risk. The smaller ones have the highest risk. But we'll get into that.
Okay.
And this is why you have to understand this. Now, obviously, when we're done with this podcast, I'm going to mail you some great graphics. It's so much easier to ascertain what I'm talking about if you see a picture.
I'm a visual learner.
A lot of Kringles or not too many Kringles. It will help.
Pringles, not Pringles chips, people.
You're right.
Pringles.
Don't confuse them with Pringles. That's a whole nother lecture. That's a dietary lecture.
So is it the genetics? It's the genetics, though, that affect the production of whether it's long and short. Okay.
And there are different SNPs, of course, that, you're going to make the few copies of Kringle 4, you're going to make a lot of copies. So it's all genetics, ultimately.
Yeah.
But you're not going to be checking those particular SNPs or anything because you're just going to measure LP little a matters. If you have a high concentration of LP little a, you don't have to go order an LPA gene. You got it.
However, if, say I do, because like I said, my tests LPA, tests the two of the LPA genes. If someone comes up homozygous or even heterozygous in both of those,
heterozygous is all that matters. It's a codominant gene. Just one gene will kill you. You don't need two.
Okay.
So homozygous, heterozygous is irrelevant with LP little a.
So if you end up with a genetic test and you look and you've never had it tested and wow, I carry a genetic risk for it, then absolutely, if you're just listening to just make sure, test it regardless, but especially if you're like, I don't know, should I go ahead and test it? And then you see it on your genetics, test it. Absolutely.
Last week we talked about ABC, G5, and G8. If that comes back homozygous, you sure as hell want to check sterols in the blood. And the same with this. If you're doing genetic testing first, maybe you did 23andMe and it said LP little a gene is there. Please go get your concentration. The odds are it's going to be high, but a lot depends on how high it is too, because the higher it is, the worse the risk. Maybe you're in a moderate zone where there might be less risk.
Yeah, thank you.
That's understanding the Kringles in the length. Now, here's where I was going to go before, and it's good for you to go in and ask questions before I go too deep, because everybody will forget. I'll confuse it more and more. It's better to clear up things. So early on, the studies seem to show, my goodness, the people with the low molecular weight apoprotein little a get a lot more heart attacks and strokes than the people with the high molecular weight. And that seemed paradoxical because, my God, if you have this monstrous long apoprotein little a, you would think that causes more havoc than the short little copy. And here's why. So I'm right back to the protein-making apparatus, the endoplasmic reticulum. So imagine that's you. You're a protein-making operator in a cell. Do you think it would be easier to construct and produce short proteins or really long proteins. Because remember, to make a long protein, you're adding amino acids one at a time. It takes a lot of time. It takes a lot of energy to make big, long proteins than it does short proteins. So to make this very easy, if your protein making apparatus, you have the genes that tell it, just make the short copies of Kringle 4 type 2, you can turn out a ton of them very quickly. Whereas it takes you a lot longer to create the monstrous, very long, high molecular weight apoprotein little a. And once you make big proteins and shoot them into the cytosol, the cell, they're subject to protein destroying enzymes called proteases. So if you make really big proteins, they get destroyed before they can even go attach to the primordial LDL particle. Whereas the little short guys, they swim right over and they bind to the LDL real quickly. So if you produce the short version of Kringle 4 type 2, the fewer copies, you will make a lot more short apoprotein little a's, and they rapidly attach to the LP little a particles, which are secreted. So the paradox is people who make the low molecular weight apoprotein little a have the highest serum LP little a concentrations, whereas the people who make the monstrous ones, yeah, a few of them go over and attach to LDLs. So there are LP little a particles with the big peptide attached, but they're far less as far as if you're counting them. Both can create havoc, but the one that's creating the havoc is a big crowd creates a havoc more than one or two little people. If you have an army of 10 guys with an army of 5,000 guys, you know who's going to cause the most havoc, the most numerous one. And this is why we now know that, first of all, you'd have to go to a research lab to get, do I have high or low molecular weight apoprotein little a, or you want Kringle 4 subtype 2 copy. All you need to know is how many LP little a particles are in your plasma. Just like with ApoB, all you have to know is how many ApoB particles there are. And if you have LP little a dash P, LP little a particle count, and that's what the nanomolar concentration is, you're counting the number of particles in nanomoles of LP little a particles. That is what we use to correlate risk. And I've already told you, above 105, too many. You got 305, even higher risk. You got under 50, no risk. In between, you're in that gray zone or so. And you might want to look to some other things we're going to talk about. So this Kringle, the type of Kringles you have, becomes important in another way. When laboratories perform assays to measure this, they're going to send in antibodies that are going to bind to this peptide. And if you have this long peptide, these antibodies might bind to a lot. So you get a false positive elevation, whereas it's easy to miss the short apoprotein little a with antibodies binding to it. Now, labs have perfected this. The standardization is very complex. They have 5 types of antibodies they send in, trying not to miss any of the binding sites. So the labs are pretty accurate nowadays, but there still can be a little, and this is why if you ever get LP little a tested and you ever want to test it again, please go back to the exact same lab you had, and then you will have more likely to have consistency in the measurements or so. And that'll be even more so once we have a drug that lowers it. You want to be using the same assay to evaluate the drug. And typically, it would be the assay that was used in a clinical trial, and labs would probably start using that assay once it gets FDA approval and everything. So those are some of the biochemistry complexities of this goofy particle. And here's back to the Kringles again. Now, I told you apoprotein little a binds to ApoB. It's actually Kringle 9 has the sulfide bonds, sulfide atoms that bind to some sulfides on ApoB. So Kringle 9 is what attaches it very strongly to ApoB. Okay, just a little factoid. You don't need to know that unless you're taking a lipid board examination. That is irrelevant in the clinical world. But listen, you got me once on this topic. I want to give you all the stuff. So how about, why is there another Kringle that's important? Yes, it's Kringle 10, and here's why. Because I told you apoprotein little a does screw up some clotting due to its effect on platelets and tissue factors and maybe plasminogen. But here is thought to be the major reason why apoprotein little a is so dangerous. It winds up that it's a sink, it's a carrier of something called oxidized phospholipids. Anything oxidized is on fire in the chemical world. You want a few little oxidized molecules in your body. It's part of the immune system to go attack killers like bacteria and stuff. But you don't want to have too many, you certainly don't want to have a lot of oxidized lipids floating around. And phospholipids are one of the lipid categories because they are very destructive to cells. So that Kringle 4 type 10 is like a magnet to bind to and grab oxidized phospholipids. And that might be good. It was thought that originally that might have been the purpose of it, to grab these dangerous oxidized things and go someplace, get cleared, wherever they get cleared. We think that's in the liver, although we don't know how they're cleared yet. And the liver can get rid of the oxidized particles or so. Kringle 4 type 10 has an amino acid called lysine enriched on it, and it binds to oxidized phospholipids. So it becomes a carrier of oxidized phospholipids. Now, what happens is if LP little a unfortunately enters your artery wall carrying oxidized phospholipids, remember it's an ApoB particle, which is going to create atherosclerosis, but now you're almost carrying an ApoB particle that's on fire because it's got oxidized phos. So it's a far worse inflammatory marker or particle once it gets into your artery wall. And that is the major reason why LP little a generates atherosclerosis, because once the ApoB particles that don't have Apo little a get into the artery wall, they get oxidized and they contribute. But the LP little a is already oxidized.
Already oxidized.
Entering your artery wall. So it just is going to create havoc a lot quicker or so. So now, very interesting. Now, a quick thing. A phospholipid is, cholesterol, people know that's a lipid. Triglycerides are actually 3 fatty acids that are stuck onto a 3-carbon sugar called glycerol. So triglycerides are 1 molecule of glycerol and 1, 2, 3 fatty acids. They could be different fatty acids, the same fatty acids, doesn't matter. That's what a triglyceride is. It carries 3 fatty acids. So a phospholipid is also in the category of glycerolipids. Triglyceride is a glycerolipid because it's 3 fatty acids stuck to glycerol. Phospholipids have a glycerol backbone, so there have to be 3 attachments to a phospholipid. 2 of the attachments are fatty acids, just like triglycerides. But the 3rd attachment is called the head group. It's a phosphorus moiety that has other things attached to the phosphorus molecule. Phosphorus is soluble, the phosphorus head group is soluble in water. So that enables phospholipids to be on the surface of cells and on the surface of lipoproteins because they interact with, they're a little bit more soluble in water, unlike the fatty acids, which hate water, they're hydrophobic. So a phospholipids is a phosphorus head group with 2 legs. There are many different head groups, and that's where the phospholipids get their specific names. Phosphatidylcholine is lecithin group. Phosphatidylethynolamine is in the lecithin group. But there are many other phospholipids that are not in the lecithin group. So that's what a phospholipid is. So when a phospholipid is on the surface of a lipoprotein, or apoprotein little a can bind certain types of phospholipids, they're carried. So when a regular ApoB particle, which has tons of phospholipids on its surface, enters the artery wall, there's an enzyme that LDLs carry called lipoprotein phospholipase A2, LPPLA2. People can order this as a blood test. It used to be called the plaque test. It shouldn't be called that anymore, but names persist. So it's LP-phospholipid-PLA2, phospholipase A2. Those glycerol backbones to either triglycerides or phospholipids, there's 3 carbons to which 3 hydroxy groups to which the fatty acid attaches. 1, 2, and 3. So the hydroxy group that's in the middle on glycerol is called SN2. The one that's on the first hydroxy group is SN1, stereospecific number, and then you have an SN3. So a phospholipase A2, which is what, the plaque test is, hydrolyzes, breaks off the fatty acid that's attached to glycerol number 2. So when you take a phospholipid that has its head group and 2 fatty acids and you remove 1 fatty acid, that is called a lysophospholipid, LYSO phospholipid. Lysophospholipids are potentially very inflammatory, very atherogenic. So if you have a particle coming in, a regular ApoB particle, and LP-PLA2 starts hydrolyzing the phospholipids, that's what makes the ApoB particles inflammatory in the artery. But LP little a is coming in already. Guess what? LP little a in the plasma is by far the lipoprotein to which the enzyme LP-PLA2 attaches. So L-lipoprotein little a is carrying a ton of this enzyme, which starts attacking phospholipids on the surface of the ApoB particle of LP little a. And once you oxidize you change them into a lysophospholipid, they get oxidized and they bind to Kringle 10. That's very complicated. Again, I'm going to send you pictures that will show this very clearly. So the enzyme that makes phospholipids prone to oxidation is LP-PLA2. And this is why if you measure LP-PLA2 and it's elevated in the blood, that is called, hey, that's like C-reactive protein. It's an inflammatory marker, but it's a very specific inflammatory marker related to the oxidation of phospholipids on the ApoB particles or on LP little a particles. Remember, LP little a particles have an LDL particle carrying a lot of phospholipids, and it's the LDL part of the LP little a that's carrying numerous copies of the enzyme LP-PLA2, and they start changing phospholipids into lysophospholipids and fatty acids, both of which can get oxidized. So it's an enzyme that creates oxidation. Bad news.
So if you're, say you already know you've got high LPA, would you then say, I recommend testing this LP-PLA2?
It's an excellent question. In the old days, yes, because that's all you had. But now, why do you want to measure that enzyme? You could, but why don't you just measure oxidized phospholipids themselves? And we now have a new blood test. The big name is oxidized phospholipids ApoB. So you're actually measuring the oxidized phospholipids that are basically on your LP little a particles. Now, the abbreviation for that test is called OX, OX little small case, PL capitals dash ApoB. APO, small letters, B, capital letter. And the only lab in the country offering that proprietary test right now is the Boston Heart Lab.
Boston Heart.
Now, last week we told you that's where many people are going to check their sterol concentrations. Somebody like yourself who's looking at a lot of things, you for sure in anybody with LP little a, or why not just do it? Measure OX-PL ApoB. Because you know that enzyme, although most of it is on LP little a particles, the other particle it traffics with are small LDLs. And you know, LDLs, they're thought might be a little bit more atherogenic than a big one. It really comes down to particle number, but if they are, it's because they carry LP-PLA2 copies, which starts oxidizing their surface phospholipids. But the best test to order for LP little a, because the tests show it now, is oxidized phospholipids on ApoB. So any of your patients that LP little a comes back high, remember earlier I said, I got 2 people with high LP little a. Who's at worse risk? The one who also has a high oxidized phospholipids on ApoB is at more risk. So if you check somebody with LP little a and that inflammatory test is not up, they have less risk. You can't turn around and say you have no risk because they probably still do. The other bad news thing about oxidized phospholipids on ApoB, it is thought that is the component on LP little a that destroys the aortic valve. LP little a can enter across the surface layer on the aortic valve cells, and once this oxidized phospholipids on ApoB get in there, they turn on genes that create bone-building substances, calcium, and over many years, your valve gets calcified, Calcified valves are going to be rigid. They're not going to operate properly. You've got a screwed up aortic valve. It's probably the second or third leading cause why people need aortic valve surgery nowadays. And until recently, cardiac surgeons who are replacing aortic valves, they don't know what the hell LP little a is, so it was never checked. You would come in and somebody had discovered your aortic valve is shot, so go have a doctor replace it now. Nowadays, you would know immediately, oh boy, let's check LP little a, because even though your valve could be corrected, you might have serious coronary artery disease or be at risk for a postoperative stroke, so you'd want to take certain measures about that. So this is one reason why the guidelines want LP little a checked in everybody once. They say around adulthood, around age 20 or so. And look, if it's high, that person is at risk not only for MACE, major adverse cardiovascular, but also for aortic stenosis. So you would listen with a stethoscope for murmur. Better yet, you start doing periodic echoes, which really give you in-depth metrics to the aortic valve. So if you have a young person with high LP little a, somebody better be watching that aortic valve. And once it gets to a certain point where it's not totally destroyed, but it's starting to be, there are certain criteria with blood velocity going through the valve, and that's when you refer early to the cardiac surgeon. They can even replace valves without cracking your chest nowadays.
You're kidding.
Yeah, percutaneously, just like a stent.
Wow.
Stent goes through your artery to your heart, but the heart valve, they just stick this contraption between your ribs and it goes right. They can robotically remove your aortic valve and sew in the new one, and you don't. And that's a big thing, because one of the worst things having to do is open heart surgery.
Yeah,
that's a very painful recovery.
Oof.
It's amazing. This is another reason to always check LP little a. So it's the oxidized phospholipids. On ApoB is a test, but most of those, if that test, say you were only doing that test, and that comes back positive, number one, you immediately check LP little a, but you also look, what is your total LDL particle count, your ApoB, and is there a predominance of small particles? And virtually everybody who has small LDLs, they are what we talked about before, the insulin-resistant people.
Yes.
Trigs will be a little high, and that's what creates the small LDL particle. So you can see how all of these things are related.
That's why I tell people, the body is such a complex system, and if you're just testing one or two things, or what, like I said before, doing the one or two genetics to look at methylation, you have to look at everything, because all this stuff plays together. Yeah. They're all having a good time.
It's like a puzzle, a jigsaw puzzle.
It is.
You put a few pieces together and you still don't know. Ultimately, you have to put a lot of pieces together before you recognize what you're dealing with.
Yeah. Remember when we were young, playing on your piece of paper, you'd have the dots and you played connect the dots, right? Yeah. Some of them you're going, but this one's over here. How do I connect it? You go through all these others to connect what the heck is happening. So
diagnostic biomarkers are just
and I have the detective brain, right? The cop will never leave me. I have this detective. I'm like, just nothing, even like when you would show up on a case, nothing was ever as it seemed, right? You just look at these base things and you go, okay, pretty simply, you would look at it and this happened. But the deeper you dive, then you see the actual connections and go, oh, now I get it. This kind of stuff is no different. That's why I love it, because it's like, the light bulb's coming on. So if someone,
so you're gonna have to listen to this podcast a few times with my graphic.
If you saw my notes, like, I will, just like the other one with the sterols last week, and I sent it over to my nurse practitioner friend who's seeing some of the sterile issues, and I said, you have to hear this. Here's the charts. It's going to help you, because we've been talking together on this. She's coming to me for help, and I'm going, wait, I've got the expert in my pocket here who's made this so much easier to understand. So it's just, again, so I'm clear, because I work well with clear direction. Say I've got a client and they test the LPA comes back elevated. Apolipoprotein B up there, small LDL particles up there, high LDL cholesterol. And we say, let's do this, the oxidized apolipoprotein protein.
Oxidized phospholipids.
Oxidized phospholipids.
OXPL.
Yes. The OXPL ApoB.
By the way, let me stop you. Do not order the test that's called OXLDL. That's irrelevant. It has nothing to do with anything we're talking about. Yeah, you must order OXPL
ApoB.
OXLDL is an irrelevant particle that has nothing to do with anything we've talked about today.
Okay. All right.
It's an old-time test.
Thank you for clarifying that. So we order the Boston Heart Lab, comes back, and they're high. At that point, would you say now we want to look at a cardiologist, maybe get a calcium score run or do deeper to see where, if there is now damage because there's the oxidation happening here?
Yes, look, once anybody, like I said, if you're starting to do it in adulthood, like the guidelines say, age 20 and whatever, I don't know that you have to do it in a 90-year-old. They made it that far, but
let them enjoy life.
and somewhat younger people, when it's more actionable, yes, you do it. So if LP little a comes back high, then you're going to have to do further investigations. Number one, you can do the plaque test if you want, but do oxidized phospholipids on ApoB for sure.
Yeah.
You'd want to rule out metabolic disarray, insulin resistance, blah, 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 hypertension and smoking, all the other homocysteine, all the other cardiovascular risk factors. Check your omega-3 index, get everything perfect. And now you have this oxidized phospholipids on ApoB. That is a higher risk person than somebody who doesn't have it. So now the question, though, comes, should you do imaging? And the guidelines would tell you this is a personal decision. You have to talk with a physician who knows what they're talking about. And you come to can it help me? Now, in general, if you didn't have LP little a, they don't advise imaging before the age of 40 in men and 50 in women, because most of the heart attacks occur after that. But when you start discovering people with things that could cause premature atherosclerosis, yes, the imaging definitely comes into the discussion there or so. So if you had people with familial hypercholesterolemia with an LDL cholesterol of 300, if they're 20 years old, you might do coronary calcium or a CT angiogram. Because again, if you have these lipoprotein abnormalities and your imaging is already showing disease, you're at super more risk than somebody whose images don't show any disease yet. That doesn't mean you ignore them. You just say, thank God I got a lot of time to treat what you have, so your images never become abnormal. So imaging comes into play. So there's no exact rules. Look, if you had a nightmare LP little a level, for sure, imaging is, I believe, indicated. But even, I think once you enter in the high risk group and you're in your 20s, for sure, if you're in your 30s or 40s, I would suggest imaging. Now, the imaging is looking for coronary calcium, and that's easy because it's cheap, maybe 150 bucks, done all over the place. But that doesn't detect the soft plaque that years later will become calcified. In the real world, the best test would be a CT angiogram looking for soft plaque. But again, thousands of dollars, not covered by insurance. The coronary calcium, you can probably afford to pay for it yourself. So that's the best next step in most people. But any imaging is going to give you more information to ascertain the risk involved with that person. And risk matters, because risk comes down to, as I said, controlling all the risk factors, but lowering ApoB very aggressively. Now, I have to teach you one more thing about ApoB, and it's the last confusing enigma with LP.
You're killing me.
LP little a is a member of the ApoB family, isn't it?
Yes.
It's an LDL.
Yes.
But it contributes nothing to your ApoB level. So although it is there, now when you measure ApoB, you're counting every ApoB containing particle. So you're counting the VLDLs, very transient particle called intermediate density lipoprotein IDL. You're counting LDLs, which are 95% of the particle, but you're also counting LP little a particles. But a normal ApoB concentration is around 1,600, 1,700 nanomoles per liter. We're measuring it in milligrams per liter, but if you want to convert it to moles, just divide by 550, which is the molecular weight of ApoB. So if you got a 100 divided by 550, you'll get your nanomolar concentration with ApoB. All right, so the LDL particle concentration of that 1,600 is 1,500. The VLDL particle concentration is less than 100 nanomoles. The IDL is 10 nanomoles, 20 nanomoles. The LP little a, if you're normal, is less than 50 nanomoles. So you can see that ApoB is really an LDL particle measurement, but it's really just measuring LDLs that don't have Apo attached to it. Now, what if you had a really high Lp concentration, 200, 300 nanomoles per liter? It starts to contribute a little bit to ApoB, but you still, if you have that many Lp particles, you probably got 2,000 nanomoles of LDL. So excuse me, piss people off when I say Lp is a minority ApoB particle. VLDLs are a minority ApoB particle. That does not mean VLDLs and Lp are not dangerous. They are. But you can't use ApoB to know whether you have too many Lp particles. You have to do the Lp(a)-P test or the mass test, milligrams per deciliter. Yes, we are measuring Lp, and if you come back at 300, go look at what your standard LDL-P test is. I like to teach your listeners everything. If they're ordering the advanced testing, which is nuclear magnetic resonance, the liposcience,
yep, NMR, yep.
Or if they're going to Quest, it's done using ion mobility transfer, IMT. They report in nanomoles per liter. Neither of those tests know the difference between a regular LDL particle and an Lp(a) particle. So when you get your NMR test back and it tells you have a high LDL particle count, you could have, if that's all you did, you could have a very high Lp(a) particle count, or you could have a normal. Because what determines
so it doesn't
your NMR total count is the LDLs that don't have Apo(a) attached to it. They dwarf the number of Lp(a) tests. So you can't use NMR to, if you have high LDLP on an NMR, you might have excess Lp(a), you might not. You have to order the Lp(a)-P test. Then you would know. Then here's the trick. If you would like to know how many of my LDL particles do not have Apo(a) attached, simply subtract Lp(a)-P from total LDLP. And then you have your two metrics. And you know why that's important? Because all of our lipid modulating drugs, except PCSK9 inhibitors, lower the regular LDLs without apoprotein(a), but they don't lower apoprotein(a). So this is why if you throw a statin at somebody who has, just because their NMR said they had a high LDL particle count, but it didn't go down as much as you thought it should, I told you last week that could be an over-absorber, not an over-synthesis, but it also could be somebody who has a lot of Lp(a) particles. They are hypo-responders to statin. They still respond, thank God.
Yeah.
And so when you write a statin for somebody with Lp(a), you're just getting rid of all the LDL particles that don't have Apo(a), but that's highly desirable. That's why you use a statin, even though, and don't even repeat your Lp(a) after you use a statin, because it's not going to change. In a moment, I'll tell you something else about that, but so I've thrown a little more confusion at you where it's a minority LDL particle, but it's very important. But I've told you, if you really know what test you're ordering, you will know exactly how many regular LDLs you got and how many Lp(a)s you got.
Yeah, this is fascinating to me. You didn't lose me on that, believe it or not. I actually get it because I've been doing these tests and I'm the one out here saying we have to test more than just cholesterol and LDL, which is what we're seeing the majority of the time with basic labs. And then the misinformation out there that's being put out there by the influencers and these podcast docs that all have the agenda around things like carnivore, and that the higher the cholesterol, the better. Our cells need it. We talked about this last week, and that's why I'm doing these podcasts, to show that you cannot listen to this. You have to look at you, and you have to do the proper tests. Take a look and see where your numbers are and work from there. But to crowd out that noise that having an LDL of 400 and 500 is okay. Like, when you don't know anything else, do the deep dive, because it's the people that come to me are in this state. Their body is just not good. and that's why I'm doing this, to put this information out there.
And there's all these, I don't know, I'll be polite, I won't use the adjectives I normally do, these negative influencers, so to speak.
Yes.
Listen to them and whatever they're spouting, and they give you just nonsense. They say to, and then listen to the two podcasts I've just done with Susan here. And who do you think knows more about lipids and lipoproteins, for God's sakes? Yeah, so please, you got to be your own advocate. You got to do your own homework. You might wind up on
Preach.
a website where somebody's telling you something that's awful bizarre. Maybe
Yeah.
listen to somebody like me with my credentials, or better yet, download the AHA, the National Lipid Association, the European download their guidelines where you have all of the experts in the world contributing to them. Who do you think is right, for God's sakes? So
Right.
that's all you have to do.
Thank
And
you.
because people don't want to take a drug, they want to believe these other guys who have magical, crazy diet cures or amazing, silly supplemental cures that do nothing. But it's, oh, I'd rather do that than go get a prescription. And God forbid I take a statin, a poisonous drug. By the way, for people, and it's an open access article in this week's Journal of the American Cardiology Association. The lead editor, Harlan Krumholz, he calls it the statin nocebo effect, virtually telling you that other than a few people getting muscle aches, a few insulin resistant people who their glucose worsens a little bit, there is zero downside to a statin. And the societies are pushing the FDA to remove, other than those side effects I just mentioned, from the statin package insert. Because people read those and they see 100 things listed that occur in nobody now that we have zillion statin. And so why are they still telling people that you can get a toothache if you take a statin or something? Because one person in a clinical trial reported they got a toothache while they were on a statin.
I think
So
the
go
biggest,
get that. It's open access, Jack, this week. Harlem Krumholtz.
I think it's the biggest thing that I hear with them is they say it increases Alzheimer's risk.
Yeah, and he goes into that where
He goes
clearly
into that as
does
well.
nothing or lowers Alzheimer's risk. So that
Wow.
is total nonsense. Google Tom Dayspring. I've done any number of podcasts on brain and lipids. It's one of my areas of expertise also. And you will, people don't know that when you measure cholesterol in the blood, your LDL cholesterol, your total, it has zero to do with the cholesterol in your brain. Your brain is a walled off system. It makes its own cholesterol. It gets zero cholesterol from the bloodstream. So if I lower your LDL cholesterol to 5 because I want to reduce your risk of heart attack, it does nothing to the brain.
Doesn't affect the We're, you know what? You're gonna have to, if you're open to it, we're gonna have to come back another time and go into that because I would love to talk about cholesterol in the brain.
Well, that's another one. Yeah, we probably ought to wait a few
Yes.
months because I've done
Yes.
two recent podcasts on that, and including a
Okay.
big one coming up that's over 2 hours long. It's going to be the best one ever. The last thing about why it's important to know your regular LDL particle count in addition to your LP little a dash P is because the drugs outside of a PCSK9 inhibitor that are going to reduce heart attacks if you have high LP little a lower the regular LDL particles. But here's what you also have to know, because the nonsense goofy people on the internet tell you statins raise LP little a and they will kill you. Actually, the data shows if you take a statin and you have high LP little a, residual risk improves, but they want to ignore the trial evidence because in some people, not in all, if you take a statin, although your LDL particle count is going down because I just told you it gets rid of the regular LDLs, and a few people, LP little a particle number goes up a little bit, 10, 20%. But look, if you've got an LP little a of 50 going up 10 and 20%, it goes to 60. If you
Yeah.
have 200, it goes to 220 or something, or 250. It doesn't change risk. So, but despite that trivial increase in LP little a particle counts, you dramatically are lowering the rest of the ApoB particles. You're saving lives. All of the guidelines written by the people who know what they're talking about, AHA, European National Lipid, tell you under no circumstances should you ever stop a statin if you prescribed it to an LP little a patient and LP little a goes up a bit. Look at ApoB, look at regular LDL particle count. I just gave you the formula. That's how you know your statin is working. So not you. So this is why another reason you should not ever even repeat LP little a if you take a statin because it's irrelevant and you might get nervous because you see LP little
Because you see it go
because you
up.
don't understand. I'm getting rid of all the rest of the ApoB, LDL, VLDL particles with that statin or ezetimibe. Ezetimibe
Yeah.
doesn't increase LP little a like a statin, but it helps lower apoprotein B. So you might not see LP little a going down on ezetimibe, but ApoB is going way down, especially if you're a hyperabsorber. So
Which
these are
was
just
last week.
important things that you have to understand.
Yeah.
And this is why it goes back to can a regular doctor manage this?
It's
How many
complicated.
doctors can recite what I just recited to you in totality?
It's complicated. That's why we're doing this. But again, if you
It
have to
just
listen to
requires a
this
little
several times,
reading.
just do it, right?
None of this is rocket science, but it does require a little bit of study and understanding.
Yeah, and like I said to you before we started today, or I might have typed it to you in the email last week, I don't geek out on science. That's not me. It's not how I'm created. However, these conversations we've been having and what I see with clients, I'm geeking out on this stuff. And I'm going, I didn't ever think I'd be like a lipid geek, but you make me want to learn more and more and more. And that's what I want for my listeners to want to learn more and be educated because regardless of the decision that you choose to make with your health, you're making it with more information, credible information, instead of just what in a Facebook group, right?
So
The,
true.
the more you have, the better the decisions you'll make. You'll feel more confident and hopefully take better steps with your health. That's what this is about, right? We're here to save a life. Is
Look,
how
I've
I
done
look at it.
thousands of lectures. I may have told you this last
Yeah.
week.
Yeah.
Anytime at the end of my lecture, I would often turn to the audience and say, because I would give them this type of lecture, I throw a lot of stuff at them and they're all taking notes. So as I walk out of the room, I say, doctors, you know what? I see you all paid attention to me. None of you left the room while I was talking. So you must have thought, is there something to what this guy is saying? I say, your brain ought to be saying, either I better know what this guy knows or I better do my homework and say he's a dumbbell. And so you got to do your own studying and reading on this. And then you will see, geez, Tom gave us a very legitimate lecture. He didn't make anything up.
Absolutely. And that's what I get when I talk to you. And that's why you make me want to learn more, which makes me a better coach. And for that, I'm just grateful. So
That's
because
an
there's not many
educator.
doing
That's
this.
my job as an educator to
Yeah.
open people's minds a little more, teach them a few factoids, and make them eager to learn more.
Yes. Can we touch on one more thing before we close?
Sure.
And that was just, we had talked briefly before we started about women being a higher risk and how menopause can affect LPA numbers.
Yep. So we told you your LP little a level is pretty static throughout life after age 5. So whatever you have, you have. But it can vary a little bit. You never do a blood test when somebody's sick, ill, inflammation. They got rheumatoid arthritis because in inflammatory states, your liver starts making a lot of proteins. And even it'll make more apoprotein little a. So that would be a false positive test if you. So you always do this test when they're in a healthy state and not ill and everything. So that's one variable. The other big variable seems to be when it's been long noted that when women go through menopause, the LP little a concentrations go up a little bit. And it's now recommended in the guidelines. They say 5 years after the menopause, if you had an LP little a done earlier in your life, you ought to repeat it. If you've never had it done, you should, of course, repeat. You should do it. So here's why. Now, I don't know that you should wait 5 years, but by 5 years, you know for sure you're really menopausal. You haven't had a period in 5 years.
You'd know.
Something's wrong. There's plausible reasons why. In general, as women go through menopause, a lot of lipids start to aggravate a little. Triglycerides goes up, insulin resistance goes up, LDL cholesterol goes up, ApoB goes up. So those are all, and there are different factors as to why that's. But one of the interesting things, I told you before that PCSK9 inhibitors are the one lipid drug that can actually lower LP little a. So you could imagine if you were on a PCSK9 inhibitor, whatever your LP little a level is, if I stop that drug, your LP little a is going to go up because PCSK9 is not being inhibited anymore. So guess what? In menopause, estrogen is a PCSK9 inhibitor. So when you lose estrogen, it's like you're coming off a PCSK9 inhibitor. Now, to a minor degree, you're not going to get a 25% worsening of
Right.
it. You might get a 5%, 10% worsening of LP little a. But here's what I like to also say. Look, so if you were normal with LP little a before menopause, it'll be a little bit higher afterwards, but you're not going from normal to the high
To a
risk
high
range.
risk.
If you were at the upper limits of normal, you may be in the lower part of the intermediate. If you were in the nightmare range, you're not dropping to you're not getting, oh my God, it's so much worse. We're high risk, you're still high risk. If you're in that moderate risk range, if you were at the highest level, say you had 100, whereas 105 nanomoles is high, maybe your 100 goes to 110, but are you really at any more risk? But it does go up. So it's important to know that. Perhaps during the menopause transition sometime, for sure, if you haven't had it done, ideal is premenopause, get it done. And as you go through menopause, once a year, it doesn't hurt to keep an eye on it. It's not like it's a $5,000 blood test. And then
No,
5 years after, you don't have to do it again after that. Unless in a few years we get a drug that shows you if you're high, this is how much you have to lower it. Then, of course, you're going to be repeating it like we repeat ApoB after we start lipid drugs nowadays. So that's the wherewithal on that.
And the other thing would be, again, to alter your lifestyle because things change when we
Yeah.
hit menopause and
Oh,
peri.
you become
So
insulin resistant
you
in
don't
general.
keep doing the same stuff you were doing, right? We change as we change. Work with the lifestyle to keep things like the ApoB down, the triglycerides, your
Fight insulin
insulin, all of
sensitivity.
it, right?
Insulin is an insulin
That's the big one.
sensitizer. You lose estrogen, excuse me, estrogen is an insulin sensitizer. When you
Yeah.
lose estrogen, you tend to become more insulin resistant. It's why type 2 diabetes is more common in older women than younger women. It's an aggravating factor. So obviously, if you're really taking care of yourself good, you would know you're insulin resistant long before menopause and you'd be
Yeah.
fighting it. But
Yeah.
you keep an eye on insulin resistant markers as you go through the transition because they might worsen. And then
That's
you just
interesting.
pick up your lifestyle.
I noticed that with me.
Yeah.
When I transitioned, I noticed, and my friend said to me, we looked at my lab. She said, "I couldn't believe I was looking at Susan's labs. I know how you live. How was your insulin or your A1C at 5.6?" And I go, now I get it. I didn't at that time go, I don't get it. Now it's making sense that how that changes, and you have to
Your genes
adapt.
are modified by the
Yeah.
environment. If you go all of a sudden in an insulin resistant environment, your genes are going to not behave properly.
No, and that's the thing. That's where we have control over our genetics, which is why I do what I do. Anything else that you?
I'm sure there is, but I think I don't have to get deeper into some of the chemistry and stuff. And it's really the laboratory, the clinical chemistry that gets complex. But
Yeah.
you don't need to know that other than pick a good lab and stick with them.
Yeah, this has been just the best couple of weeks. I never record at 7:30 in the morning. I'm like, oh my gosh. And look, I'm a morning person, but I have so much, I'm so energized after talking to you that I get so excited to dive back in. And so when when I had clients last week, I was on a high all day, and then I'm looking at more stuff. So again, you spark me wanting to learn more, and you answer my questions, and I don't feel stupid asking them. And I'm so grateful that you've taken 2 days out of your busy schedule to come and share this information for myself and my listeners. And I'm just beyond grateful.
My pleasure. And the good news for you is I don't do 7:30 a.m. Eastern Time podcast, so you don't have to get up at 5:30 to get me.
It would have looked like Deep Throat. I would have probably had pajamas on and a hood and dark in here.
So good news for
people that don't
both
know who
of
Deep Throat was, go back
Right.
and look at the Nixon.
Remind your audience on X or Twitter, I'm at Dr. Lipid and at Thomas Dayspring on LinkedIn.
I was going to bring that up, and also I'll make sure that that in our show notes that we have the link to the Family Heart Foundation.
Yes.
So we'll put that in there, and all of your information will be in there. But go check you out on X and stay up with the actual research that's happening and clinical, because you've done it all. And
Great.
all I see is the clinical part. But again, thank you so much. Please, people, share this podcast. I guarantee there's going to be a life that gets saved from these last 2 weeks of podcasts. I see it, and let's keep this going. So share, please. Dr. Dayspring, so grateful. Thank you for being here. Everybody, thank you for listening. Get out there, make it a great day. Be your most authentic self.
Thank you for tuning into my podcast. If you enjoyed this week's episode, I'd love for you to share it with someone who'd find the information useful. Please leave a review anywhere you listen to podcasts, and it'll help the information get out to others. If you're interested in seeing if we're a great fit to work together, the link is in the show notes below, where you can sign up for a free consultation with me. So go make it a great day and let your authentic self shine.